So at this point, I'm going to turn the lecture back over to our moderators. James and I obviously are available to answer any questions. We appreciate everyone's time. We're excited about the future of community paramedicine and telehealth, and we look forward to continuing to grow and learn.
Yes, thank you both. Once again, this is Jeff Frankel, the GEMS Managing Editor. That was a great presentation, very informative. We have many questions lined up. Let me pull up what we have. Is this interaction recorded, and is it able to be downloaded and attached to the PCR?
So at present, we do not record the video interaction. I'll defer to our Pulsara team on the future of that plan and process, but presently we do not record the actual video telehealth portion.
With the technology that currently exists, with certain pieces of hardware, you do have the ability to do that and attach that as a separate form, but your organization will have to decide whether or not that's a valuable tool for you.
That was a great addition there. I was just going to say, hi, this is Hannah. I'm the Director of Marketing at Pulsara, and that recording of video is certainly something that is high up on our roadmap and will be coming available soon. Thanks for the question.
Another question. They say they want to present this program to their EMS and hospital networks. These groups are more used to being siloed. What advice do you have in regards to connecting these different but interconnected care systems?
So I know in our community, the driving force was some of the certification bodies like the AHA for STEMI certifications and the ASA for stroke certifications. They have quite a bit of mandatory reporting and databases in order to meet those certifications. And so we leveraged our subspecialty lines and we showed them how Pulsara could improve care in their silo. And so by sort of demonstrating proof of concept in some of those silos, we were able to broaden Pulsara to the larger community. So I think from my personal experience, when we had our entire cardiovascular service line on board with being able to track door to EKG times and door to balloon times and all these reportables that Pulsara really makes fantastically easy to collect and track. It was an easy sell in terms of getting those silos to support it. We've done the same thing with our stroke care service line, and now with trauma. We're a level 1 trauma center here, so we have all kinds of trackables that are required, and Pulsara makes those things very easy and particularly connects the pre-hospital side of that to the hospital side of it.
Okay, great. And I guess this will be another question for Hannah. It seems that Pulsara is rural. The focus is rural. What about metro areas?
Yeah, absolutely. So Pulsara is flexible and scalable from large communities to your tiniest rural communities. So, for example, we're actually deployed across entire states, and then we also have small rural access hospitals using Pulsara up in Alaska. So, yes, we are used in rural and metropolitan areas all across the United States. There's no limit to the size of community or region, small or large, that can use it.
While we have initiated the telehealth COVID system in our rural community, UPass Regional Health Service District, we utilize it in the city of Colorado Springs, so nearly 1 million person city and suburb. So certainly works in the urban setting as well.
Okay, great. And how about when a patient is transported to the hospital? Is the data captured and sent there as well?
Yeah, so you can generate your teams within Pulsara, and they are able to capture and see that data. An example would be in our STEMI alert or stroke alert process, the patient's EKG, when the Pulsara STEMI encounter is activated, is viewable by our cardiology and cath lab teams. It's not uncommon for patients to spend less than a minute in our emergency department before going to the cath lab, or in some circumstances, a cardiologist is able to look at an EKG and de-escalate and say, no, we're not, this isn't a STEMI. We're going to evaluate the patient in the ER for an alternate reason for their EKG abnormalities. So the communication does extend into the hospital and into those individual silos like the cardiology service lines or neurology service lines.
And just to build on that, one of the really cool things from the paramedic side is that if we have a telehealth visit that then transfers or changes into a transport to the ED, that whole record can then be turned and all that information is pushed to the emergency department through Pulsara. And we don't have to then go and repeat the same information to the ED on the way in. They'll have all of that information already, which decreases the workload on the paramedic side and ensures that the same information is being shared across all the disciplines.
And can you elaborate on a statement about splitting the crew to handle 2 calls at once?
Absolutely. So we use ACT cars, or what we call alternative care transport vehicles, as part of our community paramedic program. And while our approach utilizes community paramedics and all of our paramedics are cross-trained as community paramedics, I feel like this program could be offered in a limited capacity, not through a community paramedic program. So if you didn't have the ability to invest in an entire community paramedic program, you could certainly use well-trained paramedics for this same approach on a standard 911 call. And so what we do is we have a community paramedic that's on 7 days a week from 8 a.m. to 8 p.m. But after those hours, or if a second or third call comes in, then we rely on one of our 3 911 ambulances to provide that second or third call. So what it allows us to do is the first community paramedic goes out on a COVID or what we call an EADS positive call. We can then send that second community paramedic off of the ambulance to take that second EADS call, and that keeps that third paramedic from that same ambulance available to take a third call. And that still keeps our additional 2 ambulances in service ready to go, and we're handling 3 911 calls all at the same time. If transport's necessary, then we can send one of our EMTs with that paramedic that's on scene to then transport that patient to the hospital. But more often than not, this becomes a force multiplier and allows us to literally double the amount of work we're able to do with an existing workforce.
Another question is, given the 911 call processing time constraints required for agency accreditation, do you have any suggestions or for triage to identify appropriate patients?
Yeah, so the national accrediting body for PSAP centers, and the name, I'm drawing a blank on the name right now. It's a bunch of initials, and they're an amazing organization. They actually have a protocol that they designed for pandemics. It's called Protocol 36, and it's adaptive to each community's available resources, which is great. And then the PSAP or the dispatch center with their medical director can kind of adapt those questions under Protocol 36 to make sure they're getting the information that they need. And what's really cool about that is it ties right into ET3 and the nurse triage line. So if it gets to a point where your available resources are completely depleted, then that medical director can actually turn on the next step of Protocol 36 and actually activate a triage line utilizing nursing triage or things of that nature. And while we never had to use it, we were actually able to take that Protocol 36 and adapt it in a way that if it ever had to be activated, we actually had it going out to not only nurse triage, but then the next step we were actually utilizing paramedics that were at the station or paramedics that were off duty that would actually receive those calls on their personal devices as they were pushed from the PSAP out to be triaged. And that was all done in combination with Verizon and with Pulsara. So it's such a powerful tool, and Protocol 36 allows you to maximize all your available resources to still make sure patients are getting services in what could be the worst case scenario. Like I said, we never got to that point, but Protocol 36 allows you to do that and to grow and to change, much like the disaster system grows and changes with the disaster itself. This protocol grows and changes with the pandemic.
And another question is, will the app communicate with VS sensors like ECG?
The app itself does not contain or directly communicate with our monitors. That information is just physically put in by the paramedics. So they'll arrive on scene, obtain a set of vitals, and then they just punch it into the app. I will defer to Pulsara. I'm not aware of direct connection to the monitors, but there may be something out there that we're not using.
Yeah, thanks. So Pulsara does have a public API for integrations, which allows information to be shared in real time. Some of our integrations currently include the Zoll monitor and CT imaging in the hospitals. Our data is also NEMSIS formatted, which allows for bidirectional flow into EPCRs. But if there is an integration that anyone on the call is interested in hearing more about, just go ahead and reach out to us here at Pulsara, and we can go ahead and answer that question for you.
How quickly can EMS teams adopt something like this? Does it take very long to set up and learn? They want something fast, intuitive that can help the crews work smarter together and for the patients.
Yeah, so to answer the first portion of that, how quickly can an EMS crew adopt the software program and process? I would say that the app is very intuitive and very easy to use. We have had new hires literally go through a 1-hour course on the app and how to integrate with it, and they are effectively utilizing it to activate STEMIs, strokes, and even participate in our COVID Community Paramedicine telehealth program. So I think from an education perspective, the Pulsara team has incredible resources, online videos, in-person training, virtual training, and I think that it's a very intuitive software program that takes very little time for them to learn and understand and use and operate. On the back side, from the physician side, we have a team of docs that take telehealth call, most of whom are ER docs and don't have any experience participating in virtual or telehealth. And they were good to go and utilizing the software to complete a visit with less than an hour of training and education. So I think from a deployment perspective, it does require some training. You have to play around in the app with the Pulsara team, but it seems to be easily adopted by the users. And we've had patients in their 60s and 70s utilize the app on their smart devices with little to no difficulty. I mean, a text message that has an arrow for them to click and then they're in, it is very, very user-friendly.
And the next question, I want to know how telehealth is used with a 911 call through a PSAP. Is it an RN or other provider that talks to the patient?
Yeah, so when we utilize this feature, it's generally while a crew is responding to the call. So one person will be driving. If we have a crew of 2, that's the only time we will use this, because we don't want our providers driving and talking on the cell phone at the same time. So if it's a single provider, they may reach out to the client before they start en route to the call, if it's a lower priority call. And if it's a high priority call, then they may not utilize this feature. But if there's 2 people headed to the call or it's a lower priority call, then one provider who's not driving will activate this process and reach out to the client. And the important thing to understand here is we're not providing pre-arrival instructions. That's already been done by the PSAP, and we don't want to interfere with that because that's pretty important. What we want to do is gather additional information and provide the client with additional information to prepare for our arrival to make things safer, such as the assessment and then also sample collection for the COVID-19 test. So, but it also helps us understand early, in talking to the patient and seeing the patient especially, how is their work of breathing? How is their general demeanor, their mentation? Is this a patient that's absolutely appropriate, or is this a patient that we should probably just get an ambulance started to right away? We don't want to delay that ambulance if it's necessary. So it's just an added stopgap to make sure that all the processes we have in place are working effectively.
And an important question I know everyone wants to know is, how do we handle reimbursement for the EMS side? Do you have an agreement set up with the provider that does the billing?
So from the EMS side, I'll answer the EMS side, and then I'll have Matt answer the physician side. From the EMS side, we've done a couple of things. First of all, we sit in a unique position because we are a Colorado special district. We're a health service district. So we collect both a property tax and a sales tax in our community. And we see this as an opportunity to extend the value of the services that we provide. And then for people who live in districts, they are provided a discount. But as I've said early on, if there's no margin, there's no mission. We can't possibly do this work unless we're at least breaking even. And so what we do to make sure that we're doing that is we do bill the insurance companies. Right now, most of the insurance companies aren't paying for it, but we do bill them because we want to be on their radar. We're having those conversations with them, and we feel the best way to do that is to continually remind them through billing that we're there. We're very upfront with the patients ahead of time that their insurance company may not cover it. And so what we do is we understand that not everybody's in the same financial situation. And so we bill a maximum. If we're going to bill cash, we bill a maximum charge, and it's a nominal charge. And then we send that bill to them, but it's based on their ability to pay. We utilize the sliding fee scale that's set by our state through HIPAA, which is the Medicaid arm for the state. And so we go up to 240% and a bill on a sliding scale downward from there.
I want to thank all the viewers for participating today, and I want to thank our sponsor, Pulsara, for the support. Thanks so much, everyone. We look forward to seeing you back for another webcast soon.